Welcome all to our second session. Here's the requirements again if you missed the first session. If you have already attended 10 sessions, just remember you just need to attend 2 to get credit for this quarter. If this is your first or second time in class, you need to attend all 5. If you missed one, they are online, and you just go ahead and watch the lecture and then fill out the survey at the end or the quiz at the end. The one from our first session is now up. I know a couple people had some problems reaching it because we didn't have it up or accessible yet, so it's up there now. We've had a few people, or actually quite a few people, who have done their outreach hours already. Just make sure you log those online, healthandhomelessness.com. We just want to make sure that we give you credit for the volunteer service that you do. So here you go if you missed the discussion session. And then, yeah, also if you just want to kind of look back and review some things, it's up there for your guys' benefit. So a couple more. Just keep in mind we do have sessions every week for the next 3 weeks. So next week Thursday and the following Thursday we will also have a discussion. Okay, so teeth and toes. Most of you guys have gone to the training. There is our first event on November 11th. So if you're interested in that, I believe we have the day off for Veterans Day. Yeah. So you can contact Rebecca, CC, or Brandon. NCTA, we had our first one of the quarter. We have another one coming up 3rd week of November, and then actually the 2nd Saturday of December is the one for December, just so we have a little bit of time for the break. Union Gospel Mission, as we already said, is kind of filled up, but you can keep looking on there or email Brendan if somebody wants to cancel. Then we have some backups. HSDA and Husky Smiles, look for emails about that. I believe they're still just getting set up. And then if you guys have not signed in, we're going to pass the sign-in sheet. This is pretty important for you guys to get credit. If we don't get your name down, then you're going to have to go online and kind of take the quiz just so we can get credit for the course. And without further ado, we have Dr. Peter Milgrom. He's going to talk about some silver, Diamine, Fluoride, and other public health things. Yeah. So let's give him a warm welcome.
Good afternoon. Can you hear me all right? If you can't, just wait. So I'm going to talk about something called silver diamine fluoride. And it's a tool, a dental material that you might find helpful if you were treating populations that haven't had a lot of care and a lot of tooth decay. Or you're treating fragile people for whom sort of a regular kind of intervention isn't appropriate. Or it might be an interim approach to patients. This is a topic that I've worked on for some time. I started smuggling silver diamine fluoride into the United States in 1999. And we've used it in a dental affairs clinic all that time. And I decided back then that this was kind of sad that this material wasn't available in the United States and shouldn't have to smuggle it. So I set upon the task of actually getting it cleared by the FDA, which we did last summer, and it went on the market this spring. And part of what I'm doing is actually trying to come up with other materials that are available in other countries, or materials that have been, ideas that have been developed but never actually made it to the clinic. And you'd be surprised how many there are of things like that people have actually worked on, and but they never actually got all the way out to where you could actually help people with them. And some of them are available in other countries, like this one was, or some of them are simply not available at all. So, you might see a patient like this that has some untreated tooth decay. And you're probably sophisticated enough to know that. Or you might have a patient that looks like this that also has lots of untreated tooth decay. Maybe because they've been on the street, maybe because they've been using methamphetamines, who knows? The question is, how do you stop the tooth decay and sort of get a handle on this problem so it doesn't get worse? And that's what this material is all about. So this is a patient of mine, and all these black rings around his teeth are all arrested tooth decay. What happened to him, I mean, he's not homeless, but what happened to him was he got cancer. And he had part of his tongue removed, and he had radiation to his head. And when that happens, you lose a lot of your salivary flow. And the saliva is what buffers the acids that come from the bacteria that we feed all the time in our diets. And that's what causes tooth decay, are these acids. And so if you lose the buffering capacity, if your mouth is really dry, then essentially you get beaucoup tooth decay in a very, very short period of time. So this guy, who didn't ever have a cavity before this, goes and gets part of his tongue removed, gets radiation, gets sent back to his dentist, who should know better, and 1 year later, he has tooth decay in every tooth in his mouth. Okay? And it's not the kind of tooth decay that's easy to fix, because it's like rings around all of these teeth. He ended up losing the back teeth on one side where the radiation was, because the teeth had been so badly damaged. But he's also afraid of the dentist. And he comes 2.5 hours from Seattle. So basically what I did was I put him to sleep, and I treated all of his cavities with silver diamine fluoride. And the silver causes this dark color. When dental caries arrests anyway, it gets dark. Naturally occurring arrested tooth decay. One of my pediatric friends used to call it burnout. You'd see these teeth and they would be dark brown or black, and the reason that was because the tooth decay had arrested. If you feel these lesions with an explorer, with an instrument, they're hard, they're smooth, and if you looked at them histologically, they would be basically sealed. The teeth form a kind of secondary dentin, which is actually harder than normal tooth structure, more acid resistant than normal tooth structure. And every time he comes to see the oncologist, and he's now like 5 years, so he's probably in good shape, but every time he comes to see the oncologist, I put more of this on there. And I asked him once if he wanted me to fix his teeth, and he said no. He's perfectly fine this way. He's working, he's taking care of his family, and it's a great deal. And this is the kind of thing that motivates me to try to think about, well, how can I develop some new materials, or how can I make materials available so if you're going out and you're treating vulnerable populations, that you have some tools. Because part of the problem is if you go out and you try to treat homeless people with the techniques that we teach in the dental school, you run into problems. They take too much time, they cost too much money, they often require patients to be more cooperative and follow up better. And some of the clients that we're talking about who may be sleeping on the street, or like my clients down in Longview who sleep under bridges, retired ex-veterans, who are homeless, don't have a place to go, those folks don't have a regular opportunity to brush their teeth, they don't have really good diets, they can't make regular dental appointments, even if there were dental appointments available for them. And so these kind of strategies are necessary to be part of our approach. This just shows you sort of what happens if these are cavities. I don't know if these were places the fillings fell out, because they're shaped an awful lot like where there were fillings. But this is in time 0, and you can see these guys as being yellowy. If you felt the dentin with an explorer, you would find out that it was soft. this is active tooth decay. And then 24 hours later, you see this getting darker. And here's 7 days later. Real dark. And if you feel it over time, this gets harder and harder. And this tooth decay is basically arrested. If you take curing light, like you use for composites, and you shine it on the tooth right after you do the treatment, it'll turn dark right away. But this is basically silver being deposited in the outer layers, about the outer 50 microns of the dent. And it makes a very, very hard surface. So for lots of patients, this is all you actually have to do to stop their tooth decay. I just want you to watch this video for just a second, and I'll explain why. Should be message here is that tooth decay is a bacterial disease. Okay? And you know, that poor dentist chasing bacteria with his drill is not going to solve the problem. And the reason that silver diamine fluoride is effective is because it's intensely antimicrobial. Silver compounds are used throughout medicine for like in wound care, in burn care. In many countries they wash vegetables in silver chloride in order to disinfect them. So it's not a strange thing at all that hundreds of years ago we knew that you could actually treat tooth decay with silver compounds. And so you know, the sort of the father of American dentistry, who practiced dentistry in the mid 1800s, used silver nitrate. And silver nitrate was actually used by dentists in the U.S. up until about the 50s, and then it just got lost. There wasn't a very good scientific literature about it, but what's happened is that in the meantime, the really substantial literature has developed around silver diamine fluoride, but it makes sense because it's antimicrobial. That's what it actually looks like as a compound. The reason that we don't use silver fluoride, we could use silver fluoride, but silver fluoride turns out not to be stable. If you put it in a bottle, it precipitates. It's just not very stable, and there's some issues about making it, and explosions and things like that. So they add these ammonia groups to it, and they make it more stable. And in a bottle, it has about a 3-year shelf life as long as you keep it in the dark. The part that's interesting is that this was used in Australia 80, 90 years ago. It's been available in Japan, for dentists in Japan, for 80 years, approved by the Japanese Pharmaceutical Agency, okay? But not in the United States. And people in the United States didn't even know about it. It's not in any of the textbooks. If you read your textbooks here, it's not in any of the textbooks. It's like we're isolated. And you can read stories from 300 years ago in Japan, where rich Japanese ladies painted their teeth with silver diamine fluoride in order to stain them dark. It was considered to be attractive, but they didn't get any tooth decay. So it's not a new idea, it's an idea that we haven't had in our country. So its regulatory status is that's what the bottle looks like. It's actually was cleared by the FDA, as I said. It's in the same category of medical devices as fluoride varnish. Do you all know what fluoride varnish is? Yes? Yes? Most of you do? Okay. So it's in the same category as that, and we are working really hard to move this into the category where it's actually clearly labeled for tooth decay. A lot of drugs and other agents in the United States that are used in dentistry are considered to be medical devices. And the reason for that is that it costs $1 million for a company to apply to the FDA to get a drug approved. So if you take fluoride varnish is not approved for tooth decay. Okay? Half the dentists in the United States don't know that. But it's not approved for tooth decay. It's approved for sensitive teeth. And the reason for that is that when the companies were applying to the FDA, the fees that they had to pay were very much lower than if they had to get a drug approved. And the standards are much lower. So the strategy we took, because we were public health people trying to get this done, was that we made it a medical device. Now, we ran into a lot of trouble with the FDA trying to do that. That's why it took us 7 years. But now we're actually working on a formal tooth decay indication for this, so that it's not confusing about what it's being used for. So essentially what happens is that when you get tooth decay, this is a slice of dentin, the inside of a tooth. And if you put acid on it, it gets demineralized. And these are dental tubules. These things are the fluid-filled tubules that run into the pulp of the tooth, where the nerve is, where the blood vessels are. And so in a normal condition, when people get tooth decay, this stuff, instead of being dense and very minerally, becomes porous, and it looks a lot more like that, and it gets very soft. Whereas if you treat the tooth with silver diamine fluoride, it gets hard. And you can see grossly, the difference between those two surfaces. And clinically, this is really hard. This is soft. This has been acid demineralized and continues to get worse over time unless you alter the conditions. If you take this tooth and you put it in a nice new environment where nobody's drinking Coca-Cola, it will get hard by itself just because of the calcium and phosphorus and all the things that are in the hopefully low level of fluoride from toothpaste in your diet. Okay? But if you have an overwhelming challenge of bacteria constantly producing acid, then this just gets worse. And that's what happens to a lot of the folks that you see who are living on the street. They don't have good oral hygiene. They may not be using fluoridated toothpaste. They may not even be drinking fluoridated water. They don't, they're debilitated, and so their teeth end up like that. So the rationale for this is basically that it arrests tooth decay by forming hardened, impermeable layers of dentin, this reparative dentin that is harder than and more acid resistant than normal teeth. And then you get the antimicrobial action against the bacteria that cause tooth decay. And there's some good studies that show that if you take, this was done in China, they took children who were not going to get any dental care. They had open cavities, looked like half moons in all their front teeth. They painted all the cavities with silver diamine fluoride and nothing else. And not only did the tooth decay arrest in the teeth that they were treating, but the children actually were protected against new tooth decay. And the control group was fluoride varnish. What they did was they actually compared 4 applications of fluoride varnish a year to 1 application of silver diamine fluoride. So even when we used fluoride varnish in its most intense concentration and most intense application rate, it still was about half as effective as the silver diamine fluoride. So this is a much better strategy if you want to arrest tooth decay and protect the other teeth. And of course in adults, if the teeth are sensitive, the dental tubules will actually get filled in with mineral and you'll reduce the sensitivity of teeth. When we were trying to get this approved by the FDA, we were working down in Peru, and interestingly enough, we originally thought we were going to basically take patients out of the dental clinic at the dental school. They were going to largely be poor people, and we found that the poor people don't have any dent sensitivity. Their teeth aren't sensitive. It's all the middle class and rich people who have sensitive teeth because they overbrush, brush sideways. But what they were doing was they were asking us if they could bring their friends in. It was so effective. It's about twice as effective as any other agent that's available for treating sensitivity. So the beauty of this is it's really simple, which means you can use it in settings that are atypical. But basically, if you have a tooth that's decayed, you can dry it with a little bit of gauze, and you can take a tiny amount of this stuff on a little brush and paint it on there. And dry the tooth off and wash off the excess volume, mostly because you want, it has a kind of metallic taste. So if you wash it off a little bit, you get less of a metallic taste. And of course you are preventing excess ingestion, but this stuff is extremely safe and you're not really, you don't need to prevent ingestion. So here's the child's teeth, and you can see the dark, if you look in the mirror, where this child was treated, and then the teeth just hardened. And you can put a filling over this. It's not a problem to put a filling over it, but you don't need to, especially in baby teeth or in people that where you're trying to get things under control. You have a mess like you saw in that slide of the guy who uses meth. You need to get control of the situation. So here's a way, instead of if you made a plan and you were going to see somebody over 6 months to get the big mess cleaned up, during the 6 months it would get worse. Okay, so here's a way of actually stopping. Do you have a question?
Yeah, is there a distance from the pulp that you have to place? Like, from what I've heard, and I may have got some misinformation about it, I've heard that if you place this too close to the pulp, it can be toxic to the pulp.
No, actually what's interesting is that in the clinical trials that were done, they actually looked at that question, whether they developed more abscesses in them, because these were deep cavities that they were treating. There's actually been several of these studies now, and there's no difference in the abscess rate between treating patients with fluoride varnish versus silver fluoride. So it doesn't seem to be an issue. If you put it on a tooth where the tooth decay is deep, it may be sensitive. It may bother the patient, but it doesn't seem to cause abscesses. I mean, before I actually had any clinical experience with this and was talking to people about it, some people told me that, but they didn't, that didn't prove to be the case. Yes?
About how many millimeters does it kind of get into the
About 50 microns.
So
It's not millimeters.
So
Small.
if we have like a large decay, would you use like a spoon excavator to
No.
pull out and then
No,
place it?
actually, that's a great question. So basically all we do is remove food debris. It turns out that in a clinical trial they compared excavating the tooth with an instrument and then putting silver fluoride on versus putting silver fluoride on without excavation. They did the same thing with fluoride varnish. Didn't make any difference. So there's no reason to damage the tooth further.
And it will stop it, like say it's 5 millimeters of decay, it will stop all of it?
It arrests the decay. And once you seal the decay off, I mean, you're not going to get any more acid in there. Okay, so the rest of it's going to harden up. I mean, that's pretty much true. If you take glass ionomer filling and you put it over active tooth decay, the tooth decay stops again because it's sealed off. Or if you take Pitt and Fisher sealant, plastic sealant, which is just filling material, and you put it over active tooth decay, it stops the tooth decay. All these conditions are all the same. Stop the tooth decay if you seal the tooth off. The reason this is important is because this is dirt cheap. Okay? I mean, if you compare this to the cost of sealant, for example, I mean, sealant material is very expensive. Even if you compare it to the cost of fluoride varnish, this is much, much cheaper. I mean, fluoride varnish costs like $1.25 an application. This stuff costs pennies. So this makes more sense. So this is I'm sorry it's not very clear, but this is a 14-year-old that is very sick. And this child, and is going to die. And this child developed tooth decay just all over the place. So these pictures were taken when he was post-transplant. You know, he very weak. His doctors said that he was too weak to be sedated. But he didn't like, nobody liked the way he looked. So what they did was they treated all of his teeth with silver fluoride. And then in the front, what they did was they actually made some plastic crowns for him, so he'd look better. Okay, I guess they maybe did something else in a couple of places. But basically, like, they didn't restore the lower teeth because they didn't show. A lot like my cancer patients, it didn't really care. Didn't show that much, wasn't a big issue. But again, I mean, it just shows you another example with debilitated patients, with sick patients, there's things you can do to make them better. Now let me just tell you what I'm going to show you for a second. And this blew my mind the first time I saw it. Okay, so what you're going to see is a dentist this is a permanent tooth the dentist is working on. And what he's doing is this tooth is full of tooth decay. If you took the standard dental approach, you took a big round burr and you cleaned out all the soft decay, he would need a root canal. Okay? And of course, a lot of people can't afford root canals, especially some of the people we're talking about in this class. So what they're doing here is they basically clear away the edges of the cavity, and then they treat this soft, gooey tooth decay with silver diamine fluoride. And then they put in what's called a sandwich restoration. So they seal the inside of the tooth with glass ionomer cement, and then they use composite plastic filling to restore the tooth back to function. And it's just, I mean, it's so contrary to the way things are normally done that for me, it just blew my mind. And I have subsequently done lots of this and found that, I mean, this was developed in Australia by an academic researcher. I mean, he's put a lot of effort into this for many, many years, but he's absolutely right. This stuff works fabulously. And I mean, so you have a kid, kid's got a first permanent molar. If you look at an x-ray, the tooth decay goes down right near the pulp. If you took a standard approach and you reamed that tooth out, the kid would end up needing a root canal. A lot of times those teeth have incompletely formed roots. Root canals fail in those situations often, or they require specialist treatment that's very complicated and expensive, of course. And for patients who are in poverty, that's not one of the options. So having a technique like this gives you a way of sparing teeth, and it's using a biological approach, a logical approach, to try to do that. So watch that. Oops, I'm sorry, I was doing something.
To gain access to the caries. Isolate the cavity with either rubber dam or cotton roll. Remove superficial debris and the surface layer of caries with an excavator using a number 3 round slow-speed burr. Remove the caries dentine at the dento-enamel junction and cavity floor so as to encircle the caries with sound dentine. Apply super etch 37% phosphoric acid for 5 seconds and wash away with copious amounts of water. Dry the but do not desiccate the preparation. Pierce the foil cover over the grey silver fluoride reservoir using the grey brush. Rotate the brush to push the foil to the sides of the reservoir. Bend over the brush and remove the brush from the reservoir. Apply the silver fluoride solution liberally over the cavity preparation. Commence potassium iodide application immediately following silver fluoride application. Pierce the foil over the green potassium iodide reservoir using the green brush. Rotate the brush to push the foil to the sides of the reservoir. Bend over the brush and remove brush from the reservoir. Apply the potassium iodide solution liberally over the cavity preparation. Continue applying the potassium iodide solution until the white precipitate clears from the preparation. Immediately following potassium iodide application, flush the cavity with water. Dry but do not desiccate the preparation. Place a suitable matrix system prior to restoration placement. Insert Reba SC or Reba SCHV into the preparation up to the level of the dental enamel junction. Prepare a resin-modified GIC bonding agent, Reba Bond LC. Impregnate the bond into the brush and commence condensing the glass on the cement. Prior to setting of the Reba SC, place a suitable composite resin, ice, into the preparation and condense the cavity to slightly overfill the preparation. Light cure the restoration for 40 seconds to enable the exothermic setting reaction with the composite resin to help set the Reba SC. Contour and polish the restoration with suitable rotary instruments. Completed restoration prior to occlusal adjustment.
So, the reason that he's using potassium iodide, which you can buy, and this particular product's not for sale in the United States, although they have made some attempts to get it in here, and I don't know whether they'll ever succeed or not. The reason he uses potassium iodide is because it scarfs up a lot of that excess silver, and that's what the white precipitate is, and so it doesn't stain the teeth as much as if you just use silver diamine fluoride. And we have it in the clinic. You can buy it in the drugstore. We have it in the clinic, and we use it. And he's showing the best case. In many cases, you can't, especially staining around the dental enamel junction, you can't do that. Now, this is a very conventional dental materials guy who's doing this stuff, so he's, clearing the margins and doing all that stuff, because that's the sort of the way that we make fillings. And whether you need to do all the stuff he's doing or not, I don't really know. But this technique works. And if you're in a setting, like when we go down to Longview and do our clinic down there, a lot of times you see teeth that are badly damaged like this, and the person's going to have them extracted because nobody has these techniques to use. And so this is just an interesting way of approaching a problem of stabilizing these patients. So there you can see the potassium iodide readily available. The only patients you shouldn't use this on are pregnant women. Of course, there are people who are allergic to iodine. People who can't eat shellfish. So this stuff's cheaper than multiple applications of fluoride varnish, and certainly more effective. It's cheaper than the combination of silver nitrate and fluoride varnish. Some people, before silver diamine fluoride became available in the United States, were treating patients with silver nitrate, which you can buy in the medical catalog, because it's used for treating eyes and things like that. Eye infections was many years ago was used extensively for preventing eye infections in children. And so you can buy this ophthalmologic solution from the Henry Schein medical catalog. And that's what dentists were doing. They were doing that, and then they were coating it with fluoride varnish because they had this idea that they should use the silver plus the fluoride. But that's more expensive than just using this. Part of the strategy we've used in trying to get this to the marketplace is that now there's actually a billing code, a standardized billing code available for this, which just sort of facilitates making this stuff happen. And it became available in April. We know, for example, that at least half, or maybe more than half, of all the children's dentistry specialty teaching programs have already switched to using this. I mean, it's the transfer of this technology is actually happening really fast. I'll predict that it's going to be used a lot more in adults than it will be used in children. So if you think about a frail elderly person, think about a homeless veteran, any of these kind of folks who are vulnerable and medically frail or medically compromised, this is a very nice strategy for basically stopping their tooth decay, getting a handle on the problem, and then being able to use some of the other techniques that we might want to use to make them look better or function better, but in the meantime they don't get worse. You know, old-time dentists, when they did exams, they always wrote in the chart, they saw what they thought was incipient tooth decay, and they always wrote in the chart, watch. That's what they always write, watch. And my interpretation of that is, watch it get worse. Because that's what they did. They watched it get worse, and when it got worse finally, then they put a filling in it. And so this is a strategy that basically is biologically appropriate for arresting and stopping the decay. Best information we have is that it ought to be applied twice a year. Some teeth don't arrest. We don't know exactly why, whether that's just because you don't get it coated on there well enough. So going back and being able to do it again just prevents this stuff from getting out of hand. So let me just mention silver nitrate because it's another option. It was first used, like I said, in the mid-1800s. The silver, again, reacts with the organic material, softened material in the tooth. Again, you get crystalline formation that's more acid resistant than normal tooth. Look at the paper published in 1937. It's taken us a while to use this information that's been around for a long, long time. And there was a very nice paper done in 1973. It was in the Journal of the Canadian Dental Association. Where they were showing that comparing this to other forms of fluoride, that you could arrest tooth decay more effectively with this stuff. And it suggested, that data suggested that it had to be applied a couple times a year. So it's intensely antimicrobial, and it not only protects that tooth, but it protects the other tooth as well. It's a similar kind of application process. There's some very nice videos on YouTube of a dentist down in Oregon, Steve Duffin, using this stuff on severely handicapped patients, where, again, a vulnerable population, very difficult. Oftentimes those kids have to be given a general anesthetic in order to do conventional dentistry. And so he's been managing thousands of these kids using these very simple techniques. Then you can see, again, get the same kind of look. And I don't know if you can really see this or not. But this tooth, which is going to exfoliate anyway, actually has a layer of it's a baby tooth, has a protective layer of reparative dent that's actually formed in there, which is protecting the pulp and keeping this tooth from blowing up and becoming an abscess. Okay, that's my message. I'd be glad to respond to questions. Jeff?
Any comparative studies to like the smoothing fill and last hour triage kind of approach?
That's a great question. So I don't know exactly the background of all you guys, so I don't know if they know all this vocabulary. Okay, so you can take, if you have active tooth decay and you fill the tooth decay up with cement, dental cement, and we have dental cements that release fluoride, you'll stop the tooth decay. And so a technique was developed, it was actually started in Thailand. They were training non-dentists, sort of like community aides, in the crudest of conditions, with no drills and hand instruments, to stop tooth decay. So they were doing what became popularly known as scoop and fill, which then became known as intermediate restorative treatment. No, first it was atraumatic restorative treatment. Now when it came to the United States, it was called interim treatment. Because some dentists in the United States thought that they should still do all the standard stuff they wanted to do. So they had to change the name. And in the beginning, of course, American dentists were opposed to this. But now it's become actually pretty well accepted. The answer to the question is, if you fill any tooth up with one of these kind of cements, the decay stops. You don't need to scoop it out, except to take out the food debris. And like I said, the same thing is true of sealants. Plastic fissure sealants were actually developed, this is a very old technology, developed in the 50s. First really became commercialized in the 60s, so it's a long time. But it was originally developed to put over active tooth decay. It was never developed for the purpose that it's being used today. Because most of the fissure sealants today are being put on teeth that don't have any decay in them. And most American dentists won't put plastic sealants on teeth that have decay. But they were actually developed to put over decay, and if you go back and you read the original literature, you find that it stops the tooth decay. Again, I think for the same principle, that basically what it's doing is it's sealing it off. And once you seal it off and the bacteria no longer have a source of energy in the sugars in our diet, they no longer, you no longer have any active tooth decay. So all these strategies work, basically. What I like about this is it's very simple and very cheap. Other questions? You don't want to get this on your clothes. Okay? If you get it on your lab coat, it turns black.
Does it polish off the teeth, like if you get
It doesn't stain normal teeth. It doesn't stain normal, unless you use an awful lot of it. And if you get it on the floor, the thing that we find works the best is handy, what do they call that stuff? Mr. Clean. Mr. Clean. Mr. Clean works better than bleach. But the first time you get it on your fingers, it'll come off your fingers when the tissue turns over. So it's on your fingers for about 2 weeks. But if you get it on a stainless steel counter, or you get it on the floor, you need to clean it up right away. The other thing is you need to be real careful to protect the patient's eyes and then paint the patient's face from this stuff. Because again, it'll do the same thing. And I had the experience of being in a very remote indigenous community where a staff member was helping me manage to get some of this on the child's face. It was the kind of place where I wondered whether I'd make it out alive if the parents saw this. But if you take dilute bleach, you can actually get it off. You just very gently treat it with dilute bleach. Anyway, thank you very much.